Hello, everyone. We are so excited to have you in yet another episode of Ask Your Gyna series. I'll be your host. My name is Lena Mjomba, and we have a very amazing topic. But before we get into it, allow me to introduce our amazing Daktari.
Thank you, Lena, for having me. Dr. Karanja Mwangi, you are gynecologist, obstetrician. I'm happy to be here to discuss this very important topic. And we'll continue educating you on more of health information, medical conditions in pregnancy and also in gynecology. And I'm happy to hear the questions that our viewers have for today.
Yeah,
Yes.
they are moto. Yani ziko moto.
Tutazipambana nayo vile zinakuja.
Kabisa.
Asante.
Yes, thank you so much. Daktari, kama kawaida,
Yes.
wametuma maswali mazito in this topic that we are about to get into.
Yes.
And we know that hautatuangusha.
Sitawaangusha.
You have answers for everyone who has asked.
Yes, my hope is always to use the simplest words, no medical jargon, so that the common mwananchi can understand most of these conditions. So that there are so many myths and misconceptions about conditions in pregnancy, about medical conditions. So we try and explain to them in the simplest of terms.
Amazing, amazing. I'm excited to
learn.
Excited
too.
Yeah, yes. And I think pregnancy is a very wide topic.
Yes,
and
very
today
wide.
We are in it fully.
Yes.
So the topic of the day is preeclampsia.
Preeclampsia.
Yes, you can say it.
You're pronouncing it right.
Tulikuwa tunajishukushuku lakini uko hapa kutusaidia tuweze kusema vizuri. So would you kindly expound on exactly what that is?
Okay.
Yes.
Now, preeclampsia in simple terms is just high blood pressure during pregnancy. Yes. And actually there are many forms. But preeclampsia, we usually say it's preeclampsia when the pressure rises and you're already above 20 weeks. So your pregnancy has gone up to 20 weeks. Your pressures were okay. Then after 20 weeks of pregnancy, we notice that your pressure is rising. Yes. Wow. And there are other accompanying symptoms that usually happens. We will come to that when we are discussing the symptoms. But just so that our viewers can understand.
Yes.
In broad, we call it hypertension in pregnancy.
Okay.
So there are many conditions that you call hypertension in pregnancy. Now, the first one is if a woman who is already hypertensive, she's already on drugs, even before she gets pregnant.
Okay.
Then she gets pregnant and she continues taking her drugs.
Yes.
So that one we just call it chronic hypertension.
Wow. Okay.
So they've always had high blood pressure and they're on treatment.
Yes.
Now, for preeclampsia, you've never had high blood pressure.
Oh, okay.
Then you get pregnant. Then after 20 weeks, we notice your pressures are rising. Yes.
High. Okay.
Then the other one is where you have a woman she's been on treatment. So she's having chronic hypertension. Then when she reaches 20 weeks, the pressures become uncontrollable. So she's known to have had high blood pressure.
Yes.
But then after 20 weeks, it rises again.
Yes.
So we call it superimposed preeclampsia on chronic hypertension.
Wow,
So you have chronic hypertension plus preeclampsia. And that one is usually very, very severe. Yes.
That is for someone who already had the condition.
Already had the condition.
Wow.
Then the pregnancy worsened the blood pressure. Yes.
And what causes it?
The preeclampsia.
Yes.
First of all, the pregnancy itself is a risk factor.
Okay.
And we don't really know the specific cause You know the way you'll say malaria is caused by this parasite that
Yes.
comes from the mosquito. For preeclampsia, we don't know the cause.
Mm.
So we have theories that try to explain what causes it.
Mhm.
There are so many theories. There are like 10 theories that explain, but none is exact on what causes it. But the main disease happens in the placenta.
Okay.
So whatever causes it, we don't know. But when you get pregnant up to 20 weeks,
Yeah.
when the placenta is forming, there is a way the blood vessels, let's say this is the, okay, let me draw it here. So if you have your placenta here, no, your uterus, not your placenta. I'm sure you never forgot about this topic and drawing this uterus.
No. Okay.
So this is the uterus.
Yes.
The upper part. Then the placenta usually forms here. Then you have the cord. Then you have the baby here. Then you have the membrane covering it.
Okay.
Now, when this placenta is forming,
Yeah.
because the mother's blood comes to the baby through the placenta. So there's a way the blood vessels come from the mother to the baby and from the placenta to the uterus.
Okay.
So when you have preeclampsia, these blood vessels, they form in an abnormal way.
Oh.
They don't form in the normal way.
Okay.
We don't know what causes it.
Yes.
But that attachment is not the normal attachment. So when you have that abnormality, it leads to many other problems in the blood vessels. The blood vessels of the mother, both from the brain, the kidney, the liver, and all the body parts. But we'll come to that when you're explaining the complications.
Okay.
So the main problem is in the placenta. Yes.
Wow. This is intense and it's only getting started. Wow. Okay.
It's getting complicated.
Right. So, Daktari,
Yes.
are there risk factors of developing this condition?
Yes. There are known risk factors. And the beauty is when you know the risk factors, sometimes you can prevent the disease. Now, some of the risk factors are if you've had a family history of high blood pressure or preeclampsia, maybe the sister, the mother, the auntie. So the woman might be at risk. Okay. If you get pregnant at a very early age, in teenage years, less than 20, and very late, 35, 40 years.
How late is late?
And you want to define that? But 35, 40 years. Okay, so you're at risk.
You have the risk.
Yes. Okay. If you have other conditions, let's say you've had high blood pressure and you're on treatment, you're at risk of preeclampsia. Yes. I had mentioned it can get severe in pregnancy. Yes. People who are diabetic, yes, they're at risk of developing preeclampsia in pregnancy. If you carry twins.
Oh my. Okay.
Yes, because of the placenta, sometimes there are two, and you see the abnormality is in the placenta. Yes. The pressure can also rise. Okay. If the woman is in maybe her second pregnancy, and in the first pregnancy, she had preeclampsia. So preeclampsia usually clears after pregnancy. Oh, okay. Yeah, once you deliver, you're good. You even stop the treatment.
Normal again.
Yes, you become normal, as you say.
Said that pregnant people are crazy. Pregnant women are on another level. So you become normal again.
You become normal again. Although that's to the extreme. You can't say they're crazy. But if you've had preeclampsia itself in the previous pregnancy, you're at risk of getting preeclampsia in the subsequent pregnancy. Okay. There are some conditions, we call them autoimmune conditions. like what we call lupus conditions. Yeah, those ones you're also at risk. There are many autoimmune conditions. I might not list all of it.
Yes.
Someone who's had kidney disease before, or maybe they're on treatment and they get pregnant, they're also at risk of developing preeclampsia. So when we have women, there's a way we put the risk factors. Then we see who is most at risk to develop preeclampsia. So there are ways we can prevent you from getting preeclampsia.
Okay.
Or in case you get preeclampsia, it's not as severe as someone who we didn't take measures to prevent.
Yeah.
Yes. So there are two drugs we use. One of the drugs is the normal aspirin that you know.
Oh.
You know, the normal aspirin. Yes. We usually start it when you get pregnant at around 11, 12 weeks when you're out of the first trimester. Sometimes you might have to start it early depending on the risk. So when you give them aspirin, it can help prevent.
Okay.
For women who are in population where there are dietary deficiencies in calcium, you supplement them with calcium.
Okay.
So you'll be given calcium supplements. So those two drugs have been shown to prevent preeclampsia.
Oh, interesting. And I know you haven't mentioned all the conditions, but there are those who struggle with low blood count, which translates to anemia or something.
Yes, that's anemia. That's anemia.
So what about someone who is in that state?
That category. Anemia by itself is not a risk factor for high blood pressure or preeclampsia. But what we usually say is if you have two conditions in pregnancy, then the pregnancy is at more risk because you have preeclampsia, which has its complications. Then you have anemia, which also has its own complication. But by itself, it's not a risk factor.
Okay.
Yes.
Wow. Okay. Thank you for that. And how do I know that I have it? I have preeclampsia.
Preeclampsia.
Yes.
Now, we usually say once you get pregnant. Actually, before you get pregnant, your pregnancy should be intentional. It should not be an accident. But most of the time, it's by accident. Even people who are married.
Yes.
Most of their pregnancies are unplanned. But what we advise is before you get pregnant, you're supposed to visit your gynecologist.
Okay.
Yes. Some of these things might be picked early. Maybe your pressures are high already before you get pregnant. So we need to control your pressure. We might screen for other conditions. We usually do many tests, but that is outside the topic of today. But once you get pregnant and you notice that your weight is increasing at a very fast rate, you're swelling, the limbs are swelling, the hands are swelling, the face is swelling, that is now the severe form, you need to inform your doctor. Those are some of the early signs of preeclampsia. But of importance is when you go to the clinic, they will always check your blood pressure.
Okay.
So you might not have any symptoms, but you have preeclampsia.
But it's not reflecting in any way.
Yes, you're not, you see the way someone will go to the hospital and they're told your sugars are high, but they don't have any symptoms. Then you're told you're diabetic. Same to preeclampsia. Majority of women, they are going for their normal clinics. Then when they check the blood pressure, they find that the blood pressure is high. And the normal blood pressure is supposed to be between 140 over. You have an idea?
I might embarrass myself by saying the wrong figures, so I'd rather listen to you. So those are the normal.
So 140 over 90. Below that. So the upper one should be below 140.
Okay.
The lower should be below 90. So we call this systolic and this diastolic.
Okay.
Anything that is 140 over 90 and above, that one is high blood pressure.
Okay.
Yes. So if you're above 20 weeks and we find that your pressures are high, then we qualify you to have preeclampsia.
Okay.
But of course, there are other symptoms which we will discuss that you add on this. Okay?
Wow. Okay.
Now, the other things they will do once they find your pressures are high is we will do a urine test. Now, the urine test will look for proteins in urine.
Okay.
Normally, you will not get proteins in urine during pregnancy, on a normal pregnancy. But if your pressures are high and we find urine we find proteins in urine, and we usually grade it. You usually see the test is written 1+, 2+, 3+. So that shows the severity
of the.
Yes. So you might find protein 1+, protein 2+, protein 3+. Then after that, we will send you for other tests. Because preeclampsia affects the whole body, not just the baby. All the way from the brain to the eyes, to the blood stream, to the chest, to the liver, to the kidneys. I'm seeing you're surprised. It's the whole system. So we'll send you for tests to check, is this disease so severe that it has affected the system, other places.
Yes.
So we'll do a blood test. That is the hemogram. Most people call it checking your blood level. But we are interested in checking cells that are called platelets.
Okay.
So if your platelets are low, it points towards preeclampsia. Then we'll do a test of the liver. We call them enzymes of the liver. I'll not go into the the medical jargon, but the enzymes of the liver, we do those tests. If we see they're rising and there's a level that there's a cutoff point where it goes above that, then the disease, we say it's severe.
Okay.
So we do tests for the liver. We also do the test for the kidney. We call them kidney function tests. And there are some things we look at. If they are above the cutoff, we say we qualify it to be preeclampsia.
Yes.
And of course, we don't forget the baby. So we do an ultrasound, the scan. So in the ultrasound scan, you look at the baby's growth.
Oh, yeah.
Because what preeclampsia does, once you have a problem on the blood vessels of the placenta, it affects blood flow to the baby.
Yes.
So you have reduced blood flow to the baby. So if you have reduced blood flow, it means the baby is not getting enough nutrients.
And nutrients.
Yes. So what will happen? The baby will not grow
in the rate that
in the rate that the baby is supposed to grow. So when you do the ultrasound, you expect the baby to be 2 kg. You find the baby is 1.5 or 1.6. Now that is one thing you look at the scan, the weight of the baby. The other thing, you look at the amniotic fluid.
Okay.
So if the placenta is not transmitting enough blood, there will be less fluid in the baby. So the amniotic fluid is less. And amniotic fluid is protective for the baby.
Yes.
We also look at the placenta and the blood vessels, the umbilical blood vessels of the baby. So there are some signs you can see in the placenta and in the umbilical cord, and will tell you this baby is at risk. So those are the things you look at to diagnose preeclampsia.
Yeah.
So one is the blood pressure, the urine test to look for protein, the kidney function test. We have the liver function tests for the enzymes. Good. I can see you're a good student. And of course, I'd mentioned now the symptoms that the woman came with.
Yeah.
Maybe they have a lot of swelling of the limb, the hands, the face. Yes. That's how we diagnose preeclampsia.
So after the diagnosis, what happens next in as far as treatment is concerned if it is found that this person is actually
having the disease?
Those.
Once we have confirmed you have preeclampsia, we usually classify it into two. There's the preeclampsia, we call it preeclampsia without severe features. Then we have preeclampsia
with severe features.
Severe features. That is simple. That is not complicated.
It is not.
So the ones with severe features is when you check their blood pressure. I told you the blood pressure is
140/90.
140/90, yeah?
Yes.
Now, when you have severe disease, it gets to 160.
Whoa.
So the upper one is 160. The lower one is 110.
Okay.
Yes. So that is severe disease. Yes. So the systolic is 160. The diastolic is 110. So that one you call is severe. And of course, you go to the other organs as well. The urine test, how severe is the protein in the urine? You go to the kidney, how severe are the parameters that you measure in the kidney? You go to the liver, the enzymes, how severe are the enzymes? Those are the things you look at to say if this disease is severe or it's not severe. And that will help you in the treatment. Now, if you are around, let's say, 37 weeks and above, and we pick preeclampsia, whether it's severe or not severe, we have to deliver you. We don't wait for labor to come.
Yeah.
So long as you're above 37 weeks.
Too much of a risk.
Yes, too much of a risk. And waiting, there's no added benefit of waiting.
Yeah.
So we deliver you immediately.
And the baby is developed at this point.
Yeah, at 37 weeks, the baby is okay. Now, between less than 37, you look at two things. The severity of the disease. If the woman has severe preeclampsia, above 34 weeks, you deliver.
Okay.
Above
34
weeks.
Yes.
So if someone is 30 weeks and they have severe preeclampsia, your aim is to push it up to
at least
34 for the survival of the baby.
Yes.
But you have to monitor and make sure the pressure is not rising and the baby's condition is not worsening for you to push it to 34 weeks.
Okay.
So anyone 34 weeks and above and the disease is severe, the treatment is delivery.
Yes, delivery immediately.
Now, the reason why sometimes we wait is because of the baby. So if a baby is 32 weeks, the weight is less. When you deliver them, the risk is on the lungs. The lungs is,
baby?
yes, for the baby. The lungs is usually like the last organ to mature. So when you deliver them very early, they might not be able to breathe well after delivery.
Okay.
And they will land in nursery.
Yeah.
So that's why sometimes you push. But there are some drugs you give to mature the lungs. So those ones that you wait to deliver, now you have to treat the blood pressure.
Okay.
So there are some drugs we give depending on how severe the blood pressure is. So there's a dose we give. We start from the smallest to the highest depending on the blood pressure. If the blood pressures are very high, you can also start from high as you come down.
Okay.
So control the blood pressure. Number two, there's one complication that we fear most in preeclampsia. It's called eclampsia.
Okay.
I'm sure that one you can pronounce.
Eclampsia.
Eclampsia. Now, eclampsia is a woman gets convulsions. You know convulsions? Fitting.
Yes.
Ile kifaa fama kufiti.
That one.
Yes, that one. So they get convulsions because now the disease has affected the blood vessels of the brain. Yes. And that one can be fatal.
Yes.
So any woman who has their blood pressure above 160/110, and we call it severe, there's a drug we give so that it prevents eclampsia. Yes.
Wow. Okay.
Then the other thing now, you monitor the blood pressure, you monitor the baby, you monitor the liver, you monitor the kidney as you're waiting for the baby to mature.
Yes.
then you deliver.
Okay.
So the ultimate, let me summarize it. 4 things. The ultimate treatment for preeclampsia and eclampsia is delivery.
Wow, that was like the first option.
Yes, it's delivery.
Okay.
But sometimes because the baby is not mature, we want to buy time.
Yes.
Okay?
Yes.
So if you are mature, you deliver. If you want to postpone delivery, number 2, you control the blood pressure.
Okay.
Yes, because the blood pressure is the main culprit. Then you prevent eclampsia. There's a drug you give to prevent eclampsia. Then, of course, number 4, now you monitor. Because each day that passes is a risk to the mother and to the baby.
Yes.
So long as the placenta is still in the womb, you have not treated preeclampsia. You're just trying to avoid the complications of preeclampsia.
Okay.
And you want to prevent eclampsia from happening. Now, these drugs are both to help the mother and the baby. The severest form of preeclampsia is what I have said, eclampsia.
Yes.
So the mother can get convulsions. If the mother gets convulsions, even if you are at 24 weeks, 28 weeks, 7 months pregnancy, 6 months pregnancy, 8 months pregnancy, you deliver.
With the baby underdeveloped?
Yes. Now the priority is the mother.
Yeah.
Yes. Because it can be fatal. When you have eclampsia, it's like the end point. This baby has to come out.
Wow.
You save the mother. So you deliver the baby. Sometimes you deliver even a baby who is 800 grams and they land in nursery. At least you have saved the mother.
Yes.
Because if eclampsia happens or very high blood pressure and you compromise the mother, you will also compromise the baby. Yes. So a healthy mother, a healthy baby. Yes. So you need both, but the mother is the priority.
And are there any specific reasons why it gets to that place of eclampsia?
Now, to the level of eclampsia is, you see, preeclampsia is just like the normal hypertension that people have.
Yes.
People are walking around, they are doing their activities normally. Once in a while, they say they have a headache. They take paracetamol.
Yes.
But when you go to the hospital, you're told your pressure is high. Same with preeclampsia. You're normal. You have no problem. Then you go to the clinic, you're told your pressures are high.
Yeah.
You're like, me, I'm okay. It's just because today I had a lot of stress. Some people say I climbed stairs. Then I was taking my blood pressure before I rested.
Yeah.
So they even decline treatment. Then they say they're okay. Then they go home. And the pressure continue to rise. Yes. Or they come to the hospital. The pressures are high. They're given treatment. Then they don't come for the next visit. Because when you have preeclampsia, now you don't come for the normal pregnancy visits. Now your visits are special. Yes, they're more frequent. So some of them don't come. When they finish the drugs, they're okay. We are Kenyans.
Yeah.
If you're okay, why go to the hospital?
Yeah, you feel okay.
Yes.
Even if I have an appointment tomorrow, but I'm okay.
You say, today let me work. I will go tomorrow.
Yeah.
The pressures are doing what?
They're increasing.
They're increasing.
Hey.
So you might land in the hospital.
Yeah.
And your pressures are too high. You're convulsing. Sometimes it gets to the worst that can happen to the baby. There's something we call abruptio placenta, where the placenta starts to bleed while it's still intact.
Yeah.
So the placenta bleeds, separates from the womb, and the mother starts to bleed and they get very severe pain. That one, if you delay treatment, the baby can succumb while still in the womb.
Yeah.
So the woman comes, they're bleeding, you ask them, are you perceiving any movement? They say they have not had any movements for the last 3 or 4 hours. You do a scan, Unfortunately, you find the baby is normal.
Oh,
Yes. So it can be, it's
not something
a severe
to be taken
disease.
lightly.
Yes. If you're told your pressure is high during pregnancy,
Yeah.
you need to take it
Very
serious. Yes.
Even if
And the
there's
other
no
thing we
man.
do is to prevent the severity is when you're told the blood pressure is high, you don't wait until the next visit for you to check your blood pressure.
Yeah.
So you'll be given a schedule. Like after 2 days, go even to the nearest
And take your blood.
health center or the nearest chemist, take your blood pressure, document.
Okay.
After another 3 days, go take your blood pressure, document. If it's high and you tell them this figure is high, so when it's high, they come back.
Yeah.
So that you can increase the dose of the drug.
Okay.
Yes.
Wow. So it is preventable.
It is preventable.
At the end of the day.
Yes.
It takes a lot to... It's a matter of responsibility, especially for the mother.
Yes.
Following instructions is important.
And also on our part as health workers, how to give that information.
Okay.
You should not be in a hurry just to write treatment. You have high blood pressure, take these drugs, go home. You have to educate them.
Yeah.
This is a risk if you don't take your drugs. This is a clinic follow-up, and there's a reason why we do this. And even the delivery plan, you tell them when you reach 34 weeks, we have to deliver you.
Okay.
And sometimes you can deliver you early if we see the baby is in danger, the mother is in danger.
So the consistent visits with the gyna is...
Yes, very important.
Very important, clearly. Wow, thank you so much. There was a lot to unpack, and we have unpacked it.
Yes.
As we almost wind up, I'd love for you to give us a parting shot or something that you'd love for us to know regarding this topic, even as we wind up.
Now, to the viewers, high blood pressure in pregnancy is serious. That's why in each and every clinic, the first thing they will do, they will check your weight and they will check your blood pressure. There's a reason why we check your blood pressure in each visit. So your blood pressure should be normal in each visit. If it starts to rise, or we tell you that your blood pressure is high and you need treatment, you have to take it with the seriousness that it deserves. And of course, you might be okay. You're not feeling any problem, but the disease has been detected. It has to be treated. Follow the advice of your gynecologist. Follow the advice of the health practitioners that is caring for you, and follow the instructions carefully, because high blood pressure is a danger to the mother and is a danger to the baby. And this can be prevented by taking your drugs and following the instructions carefully.
Wow. So, Doc, there's this other condition that is very familiar with preeclampsia by the name diabetes in pregnancy.
In pregnancy, yes.
Would you mind telling us more about it?
Okay. Diabetes in pregnancy. It's quite a huge topic, but I'll try to see how we can handle it.
Okay.
But it basically means your sugars or your blood glucose is higher than normal of the expected range.
Yeah.
Now, different labs have different reference ranges, but they're almost the same. So if your sugars are high, above normal, and you're pregnant, we say you have diabetes in pregnancy.
Okay.
And just like hypertension, we have several different types of, we classify diabetes. There's what we call gestational diabetes.
Okay.
Meaning your sugars are uncontrolled during pregnancy only.
Oh, okay. So
then when you deliver,
for pregnancy,
when you deliver, your sugars go back to normal.
Okay.
So that one we call it gestational diabetes.
Oh.
Then we have those women who are on treatment for diabetes. Then they get pregnant.
Yeah.
So that one we just say diabetes.
Okay.
They have been having diabetes before.
Yeah.
So when they get pregnant, they either continue with the same treatment or we change their drugs so that we give them drugs that are safe in pregnancy. So diabetes mainly means high blood sugar in pregnancy. Yes.
And what are the ranges? Like in a nutshell, like what is high and what is low?
There's the highest if it's above 11.1. That one we say that's diabetes.
Okay.
It might actually continue even after pregnancy.
Okay.
Now for gestational, it's more of we call it impaired glucose tolerance. So your body cannot tolerate the glucose. There's impaired glucose tolerance during pregnancy. So there's what you call insulin. So your body produces insulin, which controls your blood sugar, so that when you eat, your blood sugar rises.
Yeah.
Insulin is supposed to control the blood sugar.
Okay. So
for someone who has diabetes, the insulin that is produced, there's what you call insulin insensitivity. Your cells is not able to what we call metabolize glucose or consume glucose the way it's supposed to be. So the glucose remains high in the blood and it's supposed to be at a certain level. So if your glucose remains high in the blood, it will affect the mother and it will affect the baby.
Yes.
So we need to control the blood sugar during pregnancy. Yes.
Okay. This comes as an observation in our modern times.
Yes.
Has it become a very severe thing that is happening to most pregnant women?
Meaning it's become common?
Yes.
Yes. Just like the normal population. Right now we have a lot of high blood pressure.
Yes.
Have a lot of diabetes, even in young people. And it's because of the lifestyle changes that we now have. Many people are moving to towns. People are taking junk food, a lot of carbohydrates.
True.
Here in Mombasa, of course, our main kuna viazi karai, mitai, chapati. So there's a lot of sugar in the system. And a lot of physical inactivity. We all want to prosper, be in big cars, so that when I'm moving from here to the gym,
I'm driving
instead of walking to the gym.
Yes.
So a lot of physical inactivity, mainly lifestyle changes, and of course alcohol and stuff. Yeah.
Wow. So
the rate is high, both outside pregnancy and in pregnancy. And the other reason why it's also high, which sometimes we postulate why it's high, it's because women have become more informed and more sensitized. And even the doctors, we are screening it more.
Okay.
Yes. Previously, we never used to do blood sugar commonly in pregnancy.
Yeah.
But these days, it's part of the tests that are done during pregnancy. So when you do your HIV test, you do your syphilis test, all the tests, we advise you do your sugar test. Yes.
Okay. So having said all that,
yes,
what are the risk factors?
The risk factors, I've already mentioned a few in terms of lifestyle, physical inactivity, of course, the kind of meals that we take, poor eating habits. If you've had, when you're pregnant and you've had gestational diabetes before, it can actually recur again in the next pregnancy. If you've had a family history, again, like hypertension, if your sister, your mother, your auntie have had diabetes or gestational diabetes, you're also at risk.
Likely to have it.
Yes. Now, if you're overweight or obese, you're at risk of getting diabetes. If you get pregnant at an older age, again, don't ask me how old is old, But above 35, 40,
Yeah.
yes, you're also at risk of getting high sugars that are not controlled well during pregnancy. Yes. So those are some of the risk factors.
Okay.
And pregnancy itself is a risk factor.
Wow.
Yes. During pregnancy, although the science is a bit complicated, but I'll try to simplify. So during pregnancy, there are some hormones that are produced in pregnancy that might actually make you at risk of developing gestational diabetes.
Yes.
So what those hormones do, they interfere with the action of insulin and glucose metabolism during pregnancy, so that your glucose are persistently high. They are not consumed the normal way. And pregnancy also increases insulin insensitivity. So your body is not sensitive to the insulin. So the insulin does not consume the glucose the normal way.
Yeah.
So your sugars are high. Yes. So pregnancy itself is a risk factor.
And someone can screen for diabetes.
Yes, you can screen before pregnancy.
Yes.
Yes, before pregnancy you can.
Yes.
First of all, we usually educate people on symptoms of diabetes. So that one will be diagnosis. But screening, you just do your sugar test. You can either do what we call a random blood sugar, which is you just walk into a laboratory and do your blood sugar.
Okay.
There's a certain level. If it's higher than that, then you're at risk. Or we say you have diabetes. There's another one we call fasting blood sugar.
Okay.
Fasting blood sugar means you stay for many hours without eating anything. Let's say 6 to 8 hours. Then you test your sugars.
Oh.
Because if you stay for long,
yes,
we expect your sugars to be
low. Yes.
But when we test you, we find your
they're
sugars
still high.
are high.
That's a problem.
Yes. So that one we do it before pregnancy, and in the first trimester you can also do it.
Okay.
Now the one for screening gestational diabetes, between 24 to 28 weeks, that is when we usually pick gestational diabetes. You remember for hypertension we said 20 weeks?
Yes.
High blood pressure is high at 20 weeks. For gestational, we do it between 24 to 28 weeks. There's a test we call oral glucose tolerance test. It's not the normal test you do. You just check your blood sugar. So you fast for some hours. Then you go to the hospital. They give you glucose. So you take glucose. Then they test your sugar before you take the glucose, after 1 hour, after 2 hours. And they also test your urine. So your body is supposed to consume that glucose in the normal way. So if we find it's high, then we can say you have gestational diabetes. So it can be screened during pregnancy.
All right.
And we commonly screen women who are at risk. Okay? The risk factors I've mentioned.
Yes.
If they have any of that, you routinely screen.
Yes.
Yes.
So in case the risk factors are not there,
Yes,
you still screen for it.
we can screen. It's not a routine recommendation.
Okay.
Yes, but sometimes we do screen. Even those who are not having the risk factors.
The risk factors.
Yes.
All right. And what are some of the symptoms, like specifically, that project kwamba uko nayo?
Now, in terms of the symptoms, you'll be surprised. Majority of women don't have symptoms. Again, just like high blood pressure. So a woman will just come and screen and we find the sugars are high.
No.
Or they can have symptoms, but sometimes those symptoms are masked by the pregnancy. Because the symptoms of diabetes, sometimes you can be told those symptoms are of pregnancy. One, excessive thirst. You want to drink water every now and then. Two, you urinate very frequently. Yes.
Okay.
Like during the day, at night, you wake up like 6 times.
Hey.
And pregnancy, you will be told the same way, that because of the pregnancy, you will urinate many times.
Yeah.
So they might mask each other. Sometimes you find you eat a lot. Yes.
Mm-hmm.
You get those hunger pangs and you eat a lot.
Yeah.
Some women will give you there's what you call non-specific symptoms. You're always getting tired. All the tests are done, they are normal. Then when they check the sugars, they find the sugars are high. So in pregnancy, it might be difficult to have the typical symptoms of diabetes in pregnancy. Yes.
Okay. And what are the complications that come for both the mother and the baby, when you are found to have the condition?
The condition.
Yes.
Now, for the mother, if you've had diabetes for long, one of the complications in pregnancy is frequent infections. Because diabetes, when you have diabetes for long, it affects your immunity.
Okay.
So you're not able to fight diseases the way a normal person would. So you get frequent infection, discharges, urinary tract infection, upper respiratory, you're always coughing, you have a pneumonia. So frequent infections is a risk factor. The woman can go into labor and get what we call prolonged labor, or she is not able to push to deliver because the baby is big. Because one of the risk factors for the baby is having a big baby, more than 4 kg.
Oh.
Yes, so you might not be able to deliver normal.
Yes.
So women who are diabetic, the risk of CS is high. Cesarean section is high.
Yes.
They can also go into labor early, what we call preterm labor. They are at risk of that. And of course, when the baby is big and you deliver normal, there are also other complications. You get tears because the baby is big. You might bleed a lot after the delivery. Yes. Now, for the baby, the main risk is having a big baby.
Okay.
Yes. Now, when the baby is big, at the initial stage, that might not be a risk. But now during delivery.
Okay.
Of course, if the mother gets complications of prolonged labor, cesarean section, the baby is also at risk. Then when the baby is born, if you compare babies born by mothers who are diabetic and the normal babies, they're at risk of breathing problems, what we call respiratory distress. So your baby is mature, but you deliver and the baby gets a problem with the breathing. So they're taken to the nursery.
Okay.
Now, after delivery, now this one gets more complicated.
Okay.
After delivery, the baby is at risk of what we call hypoglycemia. The sugars go down. During pregnancy, the sugars were high. So even the baby, the sugars are high during pregnancy. But now when they are born, they no longer depend on the mother.
Yes, they're on their own.
They're on their own. So their sugars start going down.
Low.
So we usually measure their blood sugar at delivery. Then after every few hours, you measure.
Yes.
So you have to feed that baby frequently. Yes. And remember, the mother maybe does not have milk. So sometimes you might have to give them formula milk. Okay. So the baby is at risk of low sugars. And it's also been shown that babies who are born, mothers who are diabetic, there's a small risk of them developing diabetes later in life.
That is so sad.
Yes. Yes. So that means screening. It's very important.
Very.
And we emphasize early. You go to the clinic early enough before you get pregnant. And in case the pregnancy was unplanned, which is very common, you start your clinic early.
Okay.
Yes, so that you can pick some of the problems early in advance.
Okay, so
yes,
what are the treatment options and the best way to manage
diabetes?
Yes.
Okay, after we have confirmed.
Yes.
Because there are those who are planning to get pregnant and they're diabetic. So we usually call it it's a multidisciplinary team, meaning you will have an obstetrician, gynecologist, you will have a physician, and better still have the somebody we call endocrinologist. An endocrinologist is a physician who has specialized in matters to do with diabetes, hormonal problems.
Yeah.
So you bring them on board. Nutritionist, very important. Very, very important. In fact, should be number one.
Yeah.
Okay. So they should come on board for mothers who are already diabetic and they want to get pregnant. They should be seen by those three specialists. Make sure their sugars are well controlled. Then you check the drugs that they are using. There are some drugs which we don't recommend in pregnancy.
Yeah.
So you stop them before they get pregnant and you change the drugs. Okay? Now, once you're pregnant and we find that you have diabetes or we diagnose you with diabetes, we assemble the same team. First is lifestyle change. Lazima.
Whether you like it or not.
Lazima. If you only use drugs and you don't follow the lifestyle changes,
it will not help.
We'll achieve like 50% of what we want to achieve. And lifestyle changes involves, of course, physical activity, which sometimes might be difficult when you're pregnant.
Yeah.
So it has to be guided so that you don't do strenuous exercises, lifting of weights. So that will be guided. Even just walking, brisk walking in the morning and in the evening. Number 2 now is the diet.
Okay.
And the diet is very, very important. And you have to see the nutritionist because it's about the quality of what you eat and the quantity.
Okay.
Because we've seen people are told you need to eat brown rice, brown bread, but they're not told about the amount.
Yeah.
So yes, you're eating brown ugali, but when you're here, you can't see your neighbor on the other side. It's still carbohydrate.
Yeah.
So you're not helping yourself. So it's the quantity and the quality. And these days, what we advise is we don't give a diet prescription for everyone. It's different.
Oh, so it is custom made for you.
Customized for you, depending on your weight, any other condition that you have.
Yeah.
Pregnancy, it has how many months? What kind of work do you do? Because if someone is a manual, ni mtu wa mjengo, you might not tell him to go to the gym. He's already exercising. So you customize it to the person.
Okay.
Now the drugs come in when the lifestyle changes and the diet has failed. Actually, there's some women you diagnose them with gestational diabetes and you just control with diet and physical activity.
Oh, and they are okay.
Yes, and they're okay. But they have to be very compliant.
Yeah.
Follow the instructions and they should be ready to do frequent measuring of their blood sugar so that you make sure it's normal. Now, when that does not work, now we bring in the drugs. And the drugs are many. There are injections, which we prefer during pregnancy because of the safety of the baby. Then there are other drugs that you can take oral. Although we don't advise most of the oral drugs, some of them are not indicated in pregnancy, but there are options for that as well during pregnancy. The most important thing is that your sugars are well controlled.
Okay.
Yes. So those are the main treatments. There's the lifestyle changes, diet, physical activity, and now the drugs. Now, in terms of delivery, because for gestational diabetes, once you deliver, after some time, we taper down the drugs, and sometimes you can even stop, and you're good to go. So that one will confirm that was gestational diabetes and not the diabetes that the one that is for lifelong. So for delivery of a mother who is diabetic, depends on the sugar control.
Okay.
So if we have achieved good sugar control, they can even go up to 39 weeks.
Okay.
Yes. You'll allow them, if possible, to go and spontaneous, normal labor.
Yes.
So long as sugar is well controlled and the weight of the baby is within normal, less than 4 kg. Now, if the sugars are poorly controlled, we will deliver you early. Sometimes even before 38 weeks, depending on how the sugars are controlled. And also when we do scans, we monitor the baby. So the baby is a priority.
Yeah.
So the baby's condition and the mother's condition will determine when we deliver you.
Okay.
Yes.
So that means a lot of frequent visits.
Yes.
So how much importance should one give to
the
their visits to their doctor?
Now, when we diagnose you have high blood sugars and we start you on treatment, the first few visits will be very close.
Okay.
So that you make sure the diet changes, the physical activity, the drugs are working. After some times we can space the visits. We don't have a specific time that all diabetics should come after every 2 weeks or after every 4 weeks.
Yeah.
Again, you customize.
Yes, according to the progress.
The progress and how the sugar is controlled and the status of the mother and the condition of the baby. Because there are tests you do for the baby and there are tests you do for the mother as well. Now, there are other complications which we've not mentioned that can occur on the mother. If you've had diabetes for long, your kidneys have to be checked.
So for long, this is before. It wasn't just during pregnancy.
Not during pregnancy, before.
Yes.
So you've had diabetes for 5 years, 10 years. So there are those long-term complications that can occur. So we have to frequently check your kidneys. That is the kidney function test, and also test your urine. The urine is a very important marker of what is happening in the kidneys. So those ones should be checked frequently. The eyes can be affected. Yes, in diabetes. Because diabetes mainly affects the small blood vessels in the body. So it can affect the eyes. So sometimes we'll even advise you to see the ophthalmologist. Ophthalmologist is the doctor of the eye, the expert of the eye. So they look at the eye and see if they're okay. Their machines they use. The other bit would be sometimes the nerves are affected. If you look at people who have had diabetes for long, they easily get wounds which don't heal easily or quickly. Sure. Yes, it's because of the damage to the vessels and damage to the nerves. Yes. Now, those are long-term complications. Now, in pregnancy, if you've had diabetes for long, that is where now the physician and the endocrinologist will come in. But gestational diabetes, it has started in pregnancy. It will end with the pregnancy. They rarely get those severe complications in that period. But later in life, it's been shown if you've had gestational diabetes before, you're at risk of developing the diabetes itself in future. So you have to be on the radar of the doctors. They have to be followed up in the future.
Okay.
Yes.
So what would you advise a woman who is planning at some point to get pregnant on how to take care of themselves to avoid finding themselves in a situation where they have
the sugars are high?
Yes.
Okay. Let me be the nutritionist. Now, if we've screened you and you see you're okay, the first thing is usually screening. So that I advise you on the diet of either you're diabetic or you're not. Now, to prevent that, let's say you're at risk, maybe you're overweight or you have a family history, but yourself, you don't have diabetes. Same as what we discussed earlier, dietary changes. Of course, when you see the nutritionist, they will tell you there's that, they draw for you your plate, then they divide the plate. They tell you carbohydrates, very minimal. Then proteins, Then vitamins is what you take most. Carbohydrate is the main culprit. Wheat. We all love wheat.
We do.
Yes. So wheat should be cut. Everything should be cut. Now, in terms of physical activity, and this is where some people fear. When someone is told you exercise, they think you have to go to the gym.
Yeah.
You don't have to go to the gym. You can exercise at home. You can be walking and jogging every morning and every evening, so that this will assist you metabolize your sugars well.
Yes.
So mainly lifestyle changes, and of course alcohol.
Yeah.
If possible, cut on alcohol.
Complete.
Yes. Because if I tell you to take
your pregnancy,
generally, because if I take you take a little, what is a little?
Yeah, what
yes,
is a little?
To Karanja, maybe a little is 5 bottles of
that's little.
beer. To you, maybe it's 1 bottle.
Wow. Okay.
Yes. So it should be as little as possible, or you just stop taking alcohol.
So, to digress,
yes,
alcohol specifically, all of them, like all brands of alcohol.
Yes.
Because there's someone who will be arguing, saying, if I'm taking whiskey, it doesn't look like it's...
Alcohol is alcohol.
So generally, alcohol.
It's the quantity.
Okay.
Yes. You can be taking the safe alcohol, but you're taking too much.
Yeah. So it's the quantity.
It's the quantity.
If possible, kata kabisa.
Yes.
That's a hard one, but okay.
Yes.
Anyway. Sawa sawa, Daktari. Thank you so much. That was very educative. And just as a parting shot, what would you advise someone who is watching us and is either planning to get pregnant or is already pregnant and they're going through all these things? What would be that thing that you would actually tell them to do?
Okay. If you're planning to get pregnant, come and see Karanja.
Nice. Yes.
So that we can advise you. See your gynecologist, obstetrician. They will take you through what you're supposed to do, because you have to be ready. Your body has to be ready to get pregnant. So apart from testing your sugars and lifestyle changes, there are other tests that we will do. So you need to see your obstetrician before you get pregnant. But in case you've gotten pregnant, at the moment you know you're pregnant, visit your obstetrician, gynecologist, and they will advise you. Yes.
Wow. Thank you. Thank you very much. We will be visiting your offices. Don't worry. Tutabebana, tutakuja. Be ready.
Before you get pregnant.
Yes. So thank you so much for always being available.
You're welcome.
To answer our questions. Most of the people who are in your field would prefer we pay for consultation to get all these answers. So here we get to give people answers even without asking them for anything in return. So Mungu akubariki sana na kuongeze. All these people who are listening to you, may they translate by coming to your clinic and referring other people to come. Yeah, so thank you so much. Otherwise, thank you for joining us in this episode today. We are very, very glad that you were able to learn with us. And we continue to ask you to follow us on our social media pages, on YouTube and on TikTok, Modern Gyna Series. And also to visit Dr. Karanja. I'll ask him to give more details about his clinic.
Yes. I'm based at Jubilee Building in Mombasa, Moi Avenue. It's called Modern Gyno Clinic. And you can follow us on our social media pages. We are on Facebook, we are on Instagram, we are on TikTok, and we are on YouTube.
Yes.
Our main aim on those social media channels is to educate you on your medical conditions, either in pregnancy, gynecological conditions, how you can screen, how you can get treated, and staying healthy, reproductive system. Thank you.
Thank you so much.
Karibu.
Asanteni. And remember, knowledge is potential power. So get this knowledge so that you don't find yourself in the wrong places. Sawa sawa. See you when we see you in our next episode. God
Bye-bye.
bless you.
God bless you.